Hey, good afternoon, everybody. This is Jen Cook, and I am one of the attendings in the CVICU, bringing you another CVICU primer series. This time we're talking about hemodynamic monitoring, my favorite topic.
Hi, I am Dimitri. I am a second year resident, and I am here with to go with a few cases with you and try to learn together in this primer series with my best person in the hospital, as I say, and a person that I admire a lot, Dr. Cook.
Great, let's do this.
Alrighty, so
Jump right in.
we will jump right in. So the first case we have is a 60-year-old male, history of coronary artery disease with prior revascularizations to the LAD and circ, hypertension, hyperlipidemia, type 2 diabetes mellitus, COPD, CKD, stage 2. He presented to the hospital with shortness of breath, dyspnea and exertion, and lower extremity edema, right? Then from here we go to the exam where we see the patient is blood pressure is significant for a blood pressure of 90 over 50, heart rate in the 90s. He's a febrile, has an S3 present in auscultation, decreased breath sounds, bilateral. Also has positive JVD, hepatopulmonary reflex, positive lower extremity edema, and has cold extremity, the patients. We did echo bedside, and the person does have an LVEF of around ejection fraction, around 20 to 25% with diffuse hypokinesis. And prior left heart cath showed non-obstructive coronary artery disease, which was done recently, right? So yeah.
All right, sounds like a sick guy.
Yeah, I feel he is. Yeah, so what do we want to do with this patient when this patient comes, right? That's the question. Should we take the patient to a cath lab? Should we speak with a CVI? I feel he has to go to a CVI personally, but we shall see, right?
There definitely are some concerning things about the presentation. So what are the things that worry you the most, Dimitri, about the presentation?
All right, so for the presentation, the first thing that concerns me the more is blood pressure that's mildly low, sincerely. Like it's low, it's a systolic of 90s. He also has what we can see here, some signs of diffuse volume overload. He has JVP, he has hepatojugular reflex, he has decreased breath sounds, and lower extremity edema. But the thing that concerns me a lot is that his lower extremities are cold. And that brings us a little bit more in perfusion things, right? Like, is he perfusing? Is his heart pumping enough to perfuse? That's the thing that concerns me, honestly.
Yeah, so go ahead and show me your next slide. And let's talk a little bit about when we do right heart caths. So certainly in a situation like this, when we're suspecting cardiogenic shock, we would consider doing a right heart cath. And this patient has a systolic blood pressure of 90. And so that itself fits in the shock definition. Or if they have a normal blood pressure that is higher in a MAP drop of 30 millimeters from their baseline, could be considered cardiogenic as well. So we don't know what the cardiac index is, but we suspect because of the cold extremities that it's going to be low. And we don't know what the wedge pressure is, but based on the fact that you told me this patient has an S3 and lower extremity edema, we suspect that it's high as well. And so in this case, there's a suspicion of cardiogenic shock. But before we move on to this case, though, let's talk about other reasons why we might do a right heart cath. Have you seen them done in the ICU for other reasons?
Not me, yes. I've seen that a lot. I've done myself. I did myself a first one in my first rotation of the CVI. Was blessed with presence of a good fellow that permitted me to do one. But yeah, but I've done, and we do them a lot also for like to assess the volume status of a patient, right?
Yeah, go ahead and show us the next. That's really important because sometimes our patients are hypotensive and we're not sure why they're hypotensive. And we have in our differential distributive shock and cardiogenic shock. And in the patients that present to us in the cardiology service, sometimes it can be both. And we can be uncertain what their volume status is. Because if we're in the MICU and somebody has distributive shock, it's easy. The first three things are fluid, fluids, and fluids. But if you have a patient who has an ejection fraction of 30% and shows up with what you suspect might be an infection, you might need a right heart cath to assess their fluid status to make sure that they're appropriately filled but not overloaded. Another time that I do a lot of heart caths is under evaluation for a heart transplant or an LVAD. And so there we're looking for pulmonary hypertension, and pulmonary hypertension can actually be a contraindication to a heart transplant, and RV failure can be a contraindication to an LVAD. And so these patients we're doing a lot of right heart caths on. And then finally, we're doing right heart caths frequently in surveillance in our heart transplant patients. So after a heart transplant, our patients will have procedures, a right heart cath and a biopsy once a week, and then once a month, once a quarter, and then once a year after that. So the first year is really intense with these procedures, but we do a lot of right heart caths in those patients.
Yep. Yep. And and that so just for the people to know, if they ask you on the CVI, the recent heart transplant people have TR. Yeah, don't be tricked about a few things, but a few things we can cause TR, right? When we get the biopsies, causes tricuspid regurgitation. That's one of the causes. Yeah, and yeah. So here, as Dr. Cook said, also, we like to use volume assessment, right, for this. So I'll go to the next slide and say what are the things we measure when we get a heart cath, right? Right heart cath specifically, yeah.
Mm-hmm.
So the first thing we can go over this, Dr. Cook, if you would be so kind to.
Absolutely. I love the figure on the top of this because it's really showing us how we are floating the Swan-Ganz catheter. So the Swan-Ganz catheter is a balloon tipped catheter. So we blow up the balloon and then the balloon travels with the blood flow through the heart with a little bit of help from the operator. But if you're lucky, it goes really easily from the right atrium, as you see in the top figure. And you actually, the reason why I like this figure so much is that you see the atrial tracing. So you see an atrial tracing, and we have the atrial tracing or the CVP tracing also blown up below so that you can see that as well. Then the catheter goes from the right atrium to the right ventricle, and you can tell the waveform difference between the right atrium and the right ventricle by the increased systolic pressure. And then you have the diastolic pressure. And so the RV pressure is the systolic over the right ventricular and diastolic pressure. If you continue to pass from the right ventricle into the pulmonary artery, you see the pulmonary artery pressure, and it's differentiated. It has the same systolic pressure, but has a higher diastolic pressure. And then finally all the way out into the pulmonary capillary wedge pressure. Now, the pulmonary capillary wedge pressure is showing us the changes of pressure in the left atrium, actually, because once you blow up that balloon in the pulmonary vasculature, then you're transmitting the pressures from the left side. So this is how we get an idea of what the left ventricular and diastolic pressure is by assuming what the left atrial pressure is. And Cody, the Golden Doodle, approves with this definition, as you can see here in Arizona. My dog is in the other room. So I actually am going to ask you, Dimitri, because we are down here in the bottom figure, and the figure on the bottom of the screen is showing us that right atrial pressure tracing with the A and the V wave. And one of the things that you mentioned in the last slide is a tricuspid regurgitation that we sometimes see in our transplant patients.
Yeah.
And so tell me, what would you expect to be different on this venous tracing, this right atrial pressure tracing, if you had tricuspid regurgitation?
Oh, I feel that this person would have, I feel like a V wave that's prominent. V wave that's prominent. That's what
That's excellent. That's excellent. We did not rehearse this. And so I'm like, oh my
yes.
gosh, I hope he knows the answer.
No, a V wave that's prominent. That's
Yeah.
that's what I remember from this. But
Absolutely. You're absolutely right. So you see that A wave down there. And so the V is smaller than the A. And so if you had a lot of tricuspid regurgitation, you'd see a big V wave. And so this is something that we see. Now we're still going to report the atrial pressure as the average of the A wave. And so, but you might notice this if the patient's hooked up to the swan in the room, that you have a big V wave. And so when the patients are coming back from the cath lab, you might see A of 12 with a V of 25. And that's really telling you that the patient has a lot of tricuspid regurgitation. And on the flip side, we have an A and a V wave in the pulmonary capillary wedge pressure tracing as well. And sometimes you can see that a big V wave on the wedge, which tells us there's a significant amount of MR. And I will never forget when I was a resident, or no, I must have been a fellow, because it was was one of my attendings from fellowship. We were at the bedside in a patient who had an MI 3 days prior and was decompensated. The patient was crashing and there was a swan in, and he blew up the swan and he said, this patient has obviously a mechanical complication of an MI. This is, ischemic MR. And I was blown away that he was able to diagnose that with the swan. But what he did is he saw that big V wave on the wedge tracing and recognized it as mitral regurgitation. So this is just a little bit of the intricacies of these pressure tracings that you might not be aware of just from your first reading, and things that we can really use. And more importantly, when the patients are coming back from the cath lab and we're telling you that there was a wedge of 12 with a V of 45, you know that means mitral regurgitation.
Yeah, that's correct. I feel so. I've seen a few like this. But yeah, like a few things we can get in the right heart cath are we get the CVP, which is the central venous pressure. We get the RA pressure. We get the, as Dr. Cook said, all the pressure within the heart chambers, including the pulmonary capillary wedge pressure. And with this, we can get a full measurements of what's the cardiac output, cardiac index by thermal fix, and also we get a mixed venous, and we can calculate a few other things, including.
So do you have some numbers for me on this case?
Oh yeah, we do have a few numbers. Yeah.
All right, love some numbers.
Yep.
What do you have for me?
Here we go. So this patient had an RA of 10, had a RV of 25 over 10. So, sorry, had a PA pressure of 35 over 10 with a mean of 18, and had a pulmonary capillary wedge pressure of 25. His cardiac output was 4.0 and cardiac index 1.8 by fix, and by thermal was 4.2, 1.9.
Okay.
Yeah.
All right. So this is kind of what we suspected based on the physical exam, right? So we have a cardiac index. So what's the magic number? So in my mind, it's 2. So less than 2 is kind of the cardiogenic shock realm, cardiac index. And then we have a wedge pressure that's elevated. And so this doesn't surprise me based on the exam. But really the question is here is, what do we do next for this patient? Like, what options do we have? What have you seen done in situations like this, Dimitri?
Oh, so yeah. So how do we do for the patient?
We
have a few things here, right? My what I would do, right? I would take the E route. I'll call Dr. Cook for sure. But if it were on the night, I will do a few things, right? But the first thing that I would say, we can try a few things. So how I like to see this person, or how I like to picture this in my mind, right? And so first thing I put in the basic of 2x2 table, and I see this patient is cold and wet. I will put it in there, right?
Mhm.
So sincerely, we have to do a few things, but the first thing is support him a little with inotropes. I would say that could be the first. But sometimes we can also diuresis. It depends, right?
Mhm.
But I will let's go with diuretics in this route, right? So I will go to the next point, right?
Okay.
Diuretics. Here we go. And as you can see with diuretics, uh, this is Dr. Cook's stuff.
Yeah. So what I've done here in this figure is you see the 2x2 that Dimitri just showed us. This is exactly the same 2x2. And so our patient, so our patient fits like into this, congestive side. And here we have perfusion on the y-axis, but perfusion can be the mean arterial pressure, the stroke volume, or the cardiac output. So we've got a SWAN in this patient. So we actually know the cardiac output, and it's very borderline. It's like, right around 2, where 2 is the cutoff between being warm and cold. And so the patient's right there, and they're definitely congested with a wedge pressure of 25. So definitely to the right-hand side of this 2x2 quadrant. And so the first thing that we're going to do is we're going to talk about diuretics and what diuretics do. And so when we give a patient diuretics, it decreases the filling pressure.
Yep.
One thing you'll see is, I don't know if you recognize this curve or what this curve comes from, but this is actually the Starling curve. So this is the Starling curve transposed on the 4x4 diagram. And so one thing I'll show you, and the reason why this is here for you, is to see that when you give a patient diuretics, certainly our patient has JVD, hepatojugular reflux, lower extremity edema, definitely needs diuretics. But when we give diuretics, we're just moving to the left from the congestive symptom, from the congestive part, and therefore we're really not getting any more cardiac output. So this is to demonstrate that, I don't know if you've ever wondered, if it's ever been a mystery to you as to why when we talk about guideline-directed medical therapy, diuretics are not on the list. Well, it's because diuretics do not improve the mortality and don't have any, and in some cases can actually rev up the sympathetic drive. So we often use diuretics. We always use diuretics, but this is just to demonstrate that we're not going to get any hemodynamic benefit from diuretics. So by choosing diuretics first, I'm not going to fault you. It's certainly something that we're going to ask for because the patient's congested, but we need to recognize that we're not going to get any additional cardiac output from diuretic.
Perfect. And yeah, yep. And what do we do? So what do we do, right? What we like with this patient having this, you can always try inotrope support, I would say.
Okay.
Yeah,
Yeah.
but I would call the Dr. Cook always.
Well, you got her. She's here.
Yeah.
Yeah. So what happens with inotropes? I think that's our next slide.
Yep, it is.
Okay. So whenever we use inotropes or even vasodilators, what we're doing is we're increasing the contractility or the stroke volume. So it actually physiologically changes the situation to where the Starling curve is shifted up. And so here with vasodilators or with inotropes, we see an improvement in the contractility of the heart, and therefore you're increasing the cardiac output at the same filling pressure. And so you can imagine that you want to unload the heart, but you also want to increase contractility. So in this particular patient, because the marginal blood pressure, the answer is inotrope. So we're going to give an inotrope for this patient, but you have two choices here. You have milrinone and dobutamine. So since, and I remember, Dimitri, you said from the start that, even though we needed to talk about diuretics, you really wanted to go to inotrope. So do you have a preference? And, what are the pros and cons of dobutamine and milrinone in this situation?
So sincerely, this is a good question, right? I have no preference. There has been a few studies like it has a weird name like Peekaboo or TikTok, something. There's a trial done that it was that they trialed the two of them, and there's no benefit between the two of them. But I like dobutamine usually. I would take it if it's in the hospital and the patient doesn't have like arrhythmias or anything like that, and
That's
has.
right. Yeah, I agree. I think this patient's a good candidate for dobutamine because the heart rate on presentation was 90. So, if you have a heart rate that's already 130, or if you have someone who's an AFib with RVR, they may not tolerate the dobutamine very well. But dobutamine comes on and it has a quick, it works quickly. And so, so in a situation like this, dobutamine typically is our first choice. I will tell you though, my favorite inotrope is milrinone. My favorite inotrope is milrinone. And the reason why my favorite inotrope is milrinone is that you get pulmonary vasodilation with milrinone. And in our next segment that you guys can tune into, we're going to talk about pulmonary vasodilators and the importance of that in managing hemodynamics. But milrinone, because it is a pulmonary vasodilator and it works through phosphodiesterase, it is actually less arrhythmogenic for that reason. But as it is a phosphodiesterase inhibitor, it leads to hypotension. So the drawbacks of milrinone, one is in somebody who's already hypotensive, a lot of times they won't tolerate milrinone. And second, milrinone takes 4 hours to get to steady state. And so if you have someone who's in cardiogenic shock, you really need to start something quicker often. And so we'll go to dobutamine. But it's not unusual for me to start with dobutamine and transition to milrinone once we have some improvement of end organ function.
Yep. I've seen those type of patient that they come from their houses to be transitioned. And a few times I also seen that some people don't like to use like they have some the milrinone is preferred when a person has good kidneys. Is that correct?
Yes, thank you. Well, thank you for bringing that up. So milrinone can become tachyphylactic, or you can get built up of milrinone. So actually, if you have poor renal dysfunction, if you have poor renal clearance, then we sometimes get nervous about using milrinone in those patients because they can get even more hypotensive.
I didn't know that. Yeah.
Yes. Thanks for reminding me of that. There is a renal thing with that. So on this slide, we have vasodilators. We're not going to really talk about vasodilators in the context of this case because the patient doesn't have enough blood pressure for it. But these are our options for vasodilators, and we're going to talk about those a little bit more at a different time.
So here we go. When we take all this, when we decided to give the dobutamine, as you can see. And these were his new heart cath numbers.
Yeah, so this is basically the same set of numbers, but what we've done here is we've changed the blood pressure.
Yep.
So the patient's MAP before was like in the 60s or something like that, and now we have a mean arterial pressure of 87.
Yep, and still having a low cardiac index. But yeah, what
this is a tricky thing that we've just done, right? Yeah. It was tricky. And so if you're watching this, the biggest learning point here is that a patient that has marginal blood pressure versus a patient who has a lot of blood pressure is a very different cardiogenic shock patient. And why? It's because of the SVR. So let's go back to the previous slide because I really want to break down this SVR business.
Yeah.
The next slide where we were. There you go. Right. So you have what is the SVR? And so the SVR is the mean arterial pressure, which here we have 87 minus the CVP over the cardiac output times 80, which switches it from Wood's units to dynes per minute per whatever the unit is. And so typically, what is the SVR for this patient? Let me get my calculator out of my drawer.
Yeah, I will. This is how.
So 87 minus 10. Divided by 4 times 80. So 1,500. So 1,540.
1,500. Yeah.
Is VC. This is my scientific calculator from college, which was like 1992. Everybody. So it's had a few different battery changes, but anyway, faithful scientific calculator, 1,540. So what is wrong with this patient?
It's a high SVR, I feel, right?
Right.
Yeah.
right?
And it's important this, but yeah, this would lead us to the next question is, what do we do now?
Yeah.
Well, like I would say also always Dr. Cook is there, but I would take now when we think about a high SVR, we're thinking I see the patient that's a little bit more elevated. So if we put if I go to this right to our good curve that I enjoy a lot, this patient is currently on the red zone, I would say, but it's nearing the congestive part, right? But it is still not there. But we need more support. So now is where we go to the to reduce the afterload, because the SVR, we can translate it as the afterload. Is that correct, right?
Absolutely, absolutely. So once you're on the heart failure service, you need to start thinking like a heart failure doctor. Not talking to you, Dimitri, because you've already made the transition. You've been drinking the Kool-Aid for a while, but we think in maps.
Yeah.
Because the patient's blood pressure isn't that hypertensive. This isn't somebody that's coming into the ER and you're considering hypertensive emergency. This patient's systolic blood pressure is 120. But to a heart failure doctor, that's hypertensive because the MAP is 87. So a MAP between 60 and 65 is like a normal MAP for a heart failure patient who's on good guideline-directed medical therapy. But this patient is hypertensive to a heart failure doctor. So that MAP of 87 means that something critically must be done to bring that down. And so if you are sitting in the ventricle, let's imagine that you're sitting in the ventricle and you're seeing a left ventricular end diastolic pressure of 25, and that's the preload in the ventricle. Once the aortic valve opens, you're seeing the pressure in the aorta. So can you imagine that when the aortic valve opens and it's time for the left ventricle to contract, it looking at a blood pressure of 87 versus looking at a blood pressure of 60? That's why the SVR goes up. So by decreasing that mean arterial pressure from 87 to 60, what you're doing is you're unloading the left ventricle and allowing, with the same amount of contractility, more stroke volume. And we know that stroke volume times heart rate is the cardiac output. So in this patient who has a marginal cardiac output, if we can improve the stroke volume by decreasing the mean arterial pressure, we're going to get more forward flow. And so that's the rationale for vasodilators in patients who have cardiogenic shock.
Yeah, yeah. So yeah, that's very good, because sincerely we tend to see a patient that's like it has happened a lot, that we have a patient like on the floors or in the ED that's that has normal blood pressure supposedly, but he has an EF of he or she has an EF of like 10, or like a 15, and he is that's for the heart failure service. They consider that hypertension.
Yeah.
Severe hypertension.
And because we're talking about the heart failure service, maybe we should take a second to talk about these different agents, because there might be somebody watching who has never used nitroprusside or narcardipine. And so nitroglycerin, of course, is something that we pull off the shelf a lot because we're quite comfortable and used to using it in our patients who have chest pain related to ischemic symptoms. And so nitroglycerin is nurses can titrate nitroglycerin really confidently. One problem about nitroglycerin, though, is that patients get tachyphylactic on it. So after they've been on it for like 18 or 24 hours, the dose will escalate. So maybe you'll start on a nitro drip at like 50 or 60 and get a good effect. Well, by the next morning, you're on nitro of 200. And I don't know, I think it's like a meg per milliliter or something like that. So they're getting like 200 an hour or something like that. And like, it's a ridiculous amount of fluid, basically. I'm probably misspeaking as far as how much it is, but I'll tell you, a patient can get a liter or two of a nitroglycerin drip in 24 hours if they're at 200 an hour of nitro. And so love nitroglycerin. It is easily titrated. The nurses are very comfortable with it. We're comfortable with it. But the problem is that after 24 hours, the patients are on really high doses and you're really not getting the afterload reduction that you did initially. And so to go on IV nitroglycerin and then to switch over to like an isodil titration works nicely. or you could choose nitroprusside or nicardipine. Now, Dimitri, have you had the pleasure of being on any conversations at the bedside debating nicardipine versus nitroprusside?
Sincerely, I have, but I don't remember so well. But I have it for sure because I've seen this type of patients on
Yeah.
service.
Well, so nitroprusside is a direct vasodilator. And so it works really well. And the nurses are also quite familiar with it, titrating it. The thing to remember about nitroprusside is that you can develop toxicity to nitroprusside. And so it's not possible for us to do the monitoring for nitroprusside. It's a send out. And so we really cannot do it for many days safely in our system. And so typically we're on nitroprusside for 24, maybe 48 hours at the most, and then switching over to something oral. The other thing about nitroprusside is that the complication of the toxicity is more pronounced in patients who have renal insufficiency. And so we worry more about patients who have renal insufficiency.
Okay.
Now, the thing about nicardipine is that I actually am quite comfortable using nicardipine. But if you would have talked to me about 10 years ago, I would have been like many heart failure doctors and maybe some CT surgeons are, and think that nicardipine, being a calcium channel blocker, is kryptonite, you know, because calcium channel blockers are kryptonite to heart failure doctors because so many of our patients do poorly on the cardizem drips with AFib with RVR. But nicardipine actually is a peripheral vasodilator. And so it has no direct calcium channel effects on the heart. And so it actually can be used even in heart failure quite safely. The thing to talk about, but not everybody that you talk to will have the same comfort level with nicardipine. And I tell you, it took me years to come around, but I have come around, and I do think it's a good alternative in patients that have renal insufficiency or who need to be on IV vasodilators for a prolonged period of time. The thing to know about nicardipine is it doesn't titrate as quickly as nitroprusside or nitroglycerin. And the nurses don't have as much experience with it. So when you're on a nicardipine drip, it's important that you titrate it less quickly. So, you know, make a change and wait 15 or 20 minutes to make another change. Because I've seen patients really drop their pressures on it because the nurses are titrating it like a nitroprusside drip.
That's nice. I didn't know this. But yeah, but that's very good talk, sincerely. Because these are very, that's a bread and butter, I feel, for the services.
Yeah.
But for the patient here, I feel we do need to reduce the afterload, right? We do need the support with the dobutamine or the milrinone, but we also need to diurese at some point, right?
Well, this patient, because they're hypertensive, will get nitroglycerin drip first.
Yep.
And so may not need the inotrope. So what we do is we put them on a vasodilator and see what they do on the vasodilator, because the inotrope is just going to make them more hypertensive and create more myocardial oxygen demand.
So this patient also, I feel he's there. As you told me, can I recall that you want to do two things at a time, right? Like go up, but go towards the side. To bring the patient towards the correct place in the curve. Is that
Starling curve,
true?
right? Yeah, and so we have the Starling curve, but we also have kind of the idea of the Starling curve in our mind. And this is like a really good clinical pearl that you guys will use on the wards, which is, you know, what is the ideal wedge pressure for a patient who has heart failure? And, you know, the ideal wedge pressure is somewhere between 14 to 18. And so we're not trying to get to like a normal wedge of 8 to 10 that you might read and, you know, Up to Date or something for a wedge pressure. We're trying to get to the best wedge pressure for somebody who has a dilated ventricle, which is 14 to 18. And so what you'll do in this situation is you'll start the patient on a vasodilator. And because of the vasodilation and the decrease of the afterload, the increase to the stroke volume, you'll actually decrease the preload in the left ventricle. And so you might see the wedge pressure come down. In fact, I promise you, you'll see the wedge pressure come down from 25 to probably about, you know, 20 or so with the nitroglycerin drip. And then the other thing that will happen is that you're going to double your cardiac output. So by decreasing your afterload, increasing your stroke volume, increasing your forward flow, you're going to increase the amount of perfusion to your kidneys. And so the patient may diurese as well. And so you want to be gentle with your diuretics, because what you don't want is a patient that is then gets 40 or 80 of Lasix and then now has a wedge pressure of 10, and you're trying to manage this underfilled ventricle when you might end up hypotensive and on inotropes. That would be a mistake. What you want to do is start with the nitroglycerin or the nitroprusside, increase the forward flow, let the patient, either start with a gentle diuretic or a Lasix strip or something more gentle, so that you don't overshoot on the diuretics.
This is why I had a patient. Sincerely, I just you just clicked my brain. Like I didn't have like how do you call that? Like stopped and reflect on this. But it's true. Like I had a
We
patient.
all saw the light bulb come on.
Yeah,
It
it's
was
true.
exciting.
I had a patient who the patient had a very high SVR, and she had a high wedge, but like the two together. And we decided not to diurese, but we just treat the high SVR. And when we reswanned the patient, like we got new swan numbers the other day, without diuretics, her wedge pressure like went down like to the 8. And she had like a very high wedge pressure, which is very thing. I like that's a thing I didn't had pictured in my head.
Yeah. If you think about the hemodynamics, all these drugs start to come alive to you. It's pretty exciting.
So yeah, so this will lead us to the summary of our case, which we learned a big amount of things, I feel. So first we learned about the Starling curve and the volume status of the patient. We learned about a few key findings that could concern us more, like the cool extremity, JVP, and we learned the few significance of like having a low cardiac index, having a high SVR, and what to do with anything of that, and having a high wedge pressure accordingly, right? And most importantly, we learned like about with hypertension and heart failure, right? That heart failure, we like to go a lot with the mean arterial, because it leads us more to a perfusing pressure. So don't be tricked if the person has a blood pressure of 140 and we say like that's normal tensive for that patient, while we're seeing it with a blood pressure of 140 over 80, and that's a very big mean arterial, so we say it's hypertensive. I feel it's nice. And we also brought up this to just summarize what we spoke, and a formula that I see a lot in the fish in the fish tank in the CVI. I see that formula also there, which is very cool. And me sincerely, I like this picture here, where we can see that the heart is basically two chambers, right? Because we a few times get fixated on just the LV and we don't speak about the RV, but I feel it's a very important, the two of them, the two sides of the coin, and that will speak more, right, about this.
Yeah, stay tuned. So I love this figure. This is the first time that I've seen it. I think that I want to steal it and use it in my other presentations. But what you see here is that we've talked about the SVR in this presentation, and we're going to be talking about the PVR, and hopefully help those hemodynamics come alive in our next segment.
Yep. So that I also put in this this guide here, which will be on the handout, but at the end we're done. This was the case.
That's right. I think we pulled it off. I hope we did. But anyway, this is just a brief introduction, and this is the type of stuff that you'll be talking about on rounds when you have patients in with SONS and when you're taking care of patients in the ICU. I actually had one more thought, and so this is my conclusion, in that the patient that we presented to you today was clearly in cardiogenic shock. They were screaming cardiogenic shock. The only way that they could have been in more cardiogenic shock is if they were blue. And I have to tell you, a lot of people think that the patients that have cardiogenic shock are going to look just like that, you know, hypotensive, cyanotic, cold extremities. But remember, a patient that has marginal blood pressure and an increased SVR meets the definition of cardiogenic shock if they have end organ dysfunction. So a patient who has acutely decompensated heart failure that has acute renal insufficiency and acute hepatic insufficiency meets the diagnosis of cardiogenic shock. And so that's the final word that I want to give everybody, because it's such an important clinical pearl, because this patient that we presented screamed cardiogenic shock, but there may be more subtle presentations, and where there are many patients, even on the floor in our hospital, that meet that definition of cardiogenic shock because of the end organ hypoperfusion.
Yep. Yep.
So with that, I'll steal the last word. And I thank you guys all for joining us.